Bismillah ar-Rahman ar-Rahim. Good morning, everybody. It's a great pleasure for me to participate in this very interesting conference. And today I'm going actually to present a study that we did with our colleagues regarding the use of tofacitinib in rheumatoid arthritis. And here, just a disclaimer for the company that they did not sponsor this trial, and they have nothing to do with it. So the study is assessing actually the efficacy and safety of tofacitinib in rheumatoid arthritis, which is a retrospective study from 2 centers in Jeddah, Saudi Arabia. The idea came actually when we noticed that the oral surveillance study have shown some increased side effects, including cardiovascular disease and malignancy and other side effects. So we thought we would like to have a real practice scenarios from our own experience, and we had this kind of collaboration between us and the Armed Forces Hospital in Jeddah, and we did this study that is relatively small, but at least it gives us some ideas about what we expect to see from the real practice scenarios. We know that real practice scenarios is really good because it can enlighten us about the side effects as well as the efficacy. So I'd like first to thank our colleagues who have contributed, including our fellows, Dr. Hanan Al-Maliki and Dr. Noor Al-Jahani, who had played a great role, and also the contribution of Dr. Ahmed Al-Hazmi and the rest of the colleagues. So a quick introduction for the study. As you know, rheumatoid arthritis is a systemic autoimmune disease characterized by chronic inflammation and the destruction of the joint. It can lead to functional impairment and disability and reduced quality of life. And if you look into the 2019 EULAR recommendation, they do recommend the treat to target approach and intensive treatment using the disease-modifying anti-rheumatic drugs. And the use of the JAK inhibitors has been established now in the treatment of rheumatoid arthritis. Those patients who are moderately to highly severe or active rheumatoid arthritis who have failed or are intolerant to the conventional synthetic DMARDs. Now, the clinical trials have demonstrated that tofacitinib, whether monotherapy or in combination with conventional synthetic DMARDs, is able to considerably reduce the disease activity and also improve the health quality and function as well. So in 2012, as you know, the tofacitinib was approved by the FDA for adult patients with moderate to severe rheumatoid arthritis. And we have mentioned something about the oral surveillance study, which was mandated by the US FDA. And this study, as you know, reported higher incidence rates of MACE, major adverse cardiovascular events, and malignancy than tumor necrosis factor inhibitors. And the risk of opportunistic infections as well, like herpes zoster and tuberculosis, and some abnormalities in the liver function test were found in this study. So, as you know, still we are having the availability of these JAK inhibitors as a treatment options, and we thought we would like to see what will be the experience in our daily practice of this drug in our patients with rheumatoid arthritis. So the study objectives were, to aim is to assess the clinical efficacy, the safety, and tolerable response to the tofacitinib in rheumatoid patients encountered in routine clinical practice. And this is actually the first, probably to our knowledge, study that was done in Saudi Arabia. We have seen some studies now coming from the Gulf, like from Qatar yesterday, reporting about the same issue with JAK inhibitors, which gave us some idea that probably we are not expecting to have, a lot of side effects as has been reported from the oral surveillance. So this is a retrospective study that was conducted at the National Guard Hospital, Jeddah, and King Fahd Armed Forces Hospital. And it was starting from 2020 to 2022 when we started to collect the data. The participants were diagnosed with rheumatoid arthritis according to the classification criteria. And the inclusion criteria included all the patients who are 18 years and above and treated with tofacitinib between 2015 and 22, and evaluated at the initial visit, baseline, and every 6 months thereafter at least. So the exclusion criteria were, patient aged younger than 18 years or recent start of tofacitinib, less than 1 month. Looking into the methods, this is a patient's record were reviewed for the following information at the start of the treatment with tofacitinib. So we included actually demographic data, including the age, the gender, the comorbid illnesses, because they are really important. We have also focused on the cardiovascular risk associated, risks. So we included also the status of the rheumatoid factor and anti-CCB, and the presence of erosions and extra-articular manifestations and history of previous DMARDs and concomitant medications. We assessed the disease activity through the DAS-28, and actually the cutoff limits for remission and low disease activity. So the data that was collected for the safety included reasons for discontinuation, if any, and adverse events in the form of MACE, malignancy, serious infections requiring hospitalization, VTE, and herpes zoster were documented. Also, some lab measurements were reviewed, including the hemoglobin, platelets, leukocyte counts, lipid profile, and liver function tests. So if you look into the age of the patient, that was really the mean age of the patient was 48 years, which is kind of interesting because we are trying here to follow the recommendations from the guidelines. And in fact, this is different from what we have seen from the oral surveillance. The mean age for the patient in the oral surveillance was 60 years. And in fact, about 1/3 of the patients were more than 65. So this is a little bit different from what we have seen in the oral surveillance. Of course, the gender duration of the disease was around 10 years, and the females were the majority in this study. As always in rheumatoid arthritis, we're talking about 84% of the patients. And interestingly, looking into the obesity in the populations, we are talking about 48% of the patients were having a BMI more than or equal to 30%. Looking into the comorbidities, only 1/3 of the patients, like around 34%, did not have any comorbidities. However, 2/3 of the patient had comorbidities, including diabetes in about 1/3 of the patients. Hypertension is almost in 50% of the patients, and ischemic heart disease was only 4% of the patients. In fact, if you look into the oral surveillance, the patients who had ischemic heart disease were almost 11%. The rheumatoid factor or CCB status is seen in 86% of the patients here, and presence of erosions was only in 30%. We know that those patients were already on treatment, and including also some biologics before who failed either conventional synthetic DMARDs or biologics. So probably that has helped in reducing the structural damage in this group of patients. Extra-articular manifestations was seen in 14%, and those patients, almost 1/3 of the patient had severe disease, and 2/3 had moderate disease activity. So if you look into the treatment regimens those patients have used, as a monotherapy, when you talk about tofacitinib, is seen in 1/3 of the patients. However, 2/3 of the patients were using it in addition to the other conventional synthetic DMARDs. And you can see the different DMARDs used here. Probably the commonest among them is methotrexate in about 56% of the patients. Again, because those patients are having severe, moderately severe, or moderate disease at least, good percentage of those patients, around 50%, had steroid as well in addition. So the treatment regimens, if you look into here, those patients had already given a biologics in about 2/3 of the patients. 74% of the patients had received biologics, and at least 1 or 2 of the biologics that have failed in those patient populations. And the same thing for the DMARDs, the conventional synthetic DMARDs. If we look into the efficacy for the patients who have been treated with tofacitinib here, we are seeing about 50% achieved remission, which is really a good indication that the drug works well. And in about 30% of the patients, they had low disease activity. If you look into the other observational studies that have looked into similar things, we are having almost similar data to what has been reported in the literature. Now, the time to achieve the treatment target was between 12 and 26 weeks. Now let's look into the treatment discontinuation and the reasons for the discontinuation. The total duration of therapy was about 18 months. If you look into the median duration for the oral surveillance, it was like 4 years. So we are here having about 18 months, like a year and a half. The discontinuation was seen in about 30% of the patient, and the reasons included lack of efficacy in about 14% of the patients. Some of the patients got pregnant and it has to be stopped, and some adverse events in 10% of the patients. If you look into the adverse events here, which is important, that's what we were trying to focus on to see if we are going to have any bad signals in this data. So we've seen about 6% having dyslipidemia. Herpes zoster was reported in about 4% of the patients, and serious infections requiring hospitalizations in about 4% in the form of UTI or pneumonia, and only 2% had neutropenia. However, if we look into the VTE, MACE, or malignancy, fortunately, none of the studied patients developed serious adverse events among these outcomes, which is really quite reassuring, at least for the period of the time that we have studied them. The laboratory changes, for example, showed some patients had an element of increase in the lipids as expected. Leukopenia is only 2% of the patients, and neutropenia less than 1,500 in 2% of the patients. So none of the studied patients developed lymphopenia, an increase in the liver enzymes, or creatinine. So we looked into the predictors of achievement of the treatment target. Are there any predictors in this patient cohort that might help us predict they are going to respond to the treatment? We did not find any significant relationship between the different characteristics, and including the demographics at baseline, the disease characteristics, or previous treatment regimens. So you can see we looked into the patient's demographics, the duration of the disease, the comorbidities, serology, presence of erosions, extraarticular manifestations, and it seems that there is no any associations or predictors of response. Again, in terms of the monotherapy, the drug was given as monotherapy or in combinations with conventional synthetic DMARDs, it seems that it works despite all situations. So regarding the discussion of this study, this retrospective real-world study analyzing the patient with rheumatoid arthritis treated with tofacitinib from 2 centers in Western Saudi Arabia, it showed a good response to the tofacitinib treatment even without concomitant use of methotrexate, and in patients who had multiple biologic DMARDs failure. The tofacitinib significantly reduced the disease activity, and we've seen that about 50% achieved remissions and 30% achieved low disease activity. So we are talking about 20% who did not respond. Looking into the adverse events leading to the discontinuation, we've seen that some patients, had discontinuation due to inefficacy or due to the presence of some side effects or because of pregnancy. So in our study, the most common infectious adverse events were herpes zoster, which is seen in 4% of the populations in this study. In fact, it's more or less similar to what has been reported in the literature, which is ranging between 3.7% to 4% or even more. So few patients developed an increase in the LDL cholesterol, which is one of the expected features seen with these kind of treatments. However, neither hepatitis B reactivation nor tuberculosis was reported, and none of the enrolled had VTE, MACE, or malignancy. As usual, like in this study, there is limitations, and one of the limitations of our study is a small number of the participants, which reached about 50 patients, and the duration of the study is probably limited, about 18 months in total when we talk about the duration, mean duration, although some patients had it for longer. But really, we need to have a longer study to capture probably some of the side effects like MACE. But at least for this time durations, we see no increased risk if you choose your patients rightly, like in this patient population who are younger, a relatively younger population than what has been reported in the oral surveillance. In fact, the patients in the oral surveillance with 50 years and older having at least one risk factor for cardiovascular disease. So now we do not recommend to start this medication in patients who are more than 65 years of age or having ischemic heart disease to be able to reduce the possibility of developing side effects. Tofacitinib, in conclusions, is a valuable and well-tolerated treatment option for rheumatoid arthritis patients. And the tofacitinib induced high rates of low disease activity and remissions in moderate to highly active rheumatoid arthritis as monotherapy or in combination with conventional synthetic DMARDs, which reinforces that tofacitinib effectiveness in real clinical practice that has been established even from other studies. So with this, I thank you for listening and thank the audience for their attention.